Our next speaker is Sue Kildea. She's worked in this area for an awful long time. Everyone who knows her knows that she bangs on about birthing in the bush. Even if it's some completely unrelated topic, she manages to squeeze it in. So we're lucky to have her today to be able to present the evidence and opportunities around birthing in country and birthing in the bush. Please welcome Sue.
Thank you. Thanks, Sue. Fantastic to be here. Before I start, I'd like to acknowledge the traditional owners of the land that we're standing on today, and fabulous to be here for Birthing on Country Summit, which is most definitely close to my heart. I'm not going to talk a lot about the stats. I think we all know the statistics, and what we do know is that these two little babies, both born in Australia today, don't have the same chances or opportunities as they go through their life. There's a fabulous quote in the Close the Gap report which says, "It's inconceivable that a country as wealthy as Australia cannot solve a health crisis affecting less than 3% of its population." We're talking about 10,000 mothers and babies being born every year, and I think we absolutely can make a difference about that. The National Maternity Services Plan is a plan that was put out in 2010, signed by all health ministers across the state, and it's got 4 action points that are really important for the maternity services. The first action point is to increase access for women and their family members, particularly in remote Australia, for high-quality maternity care, and that's something that we really need to work on. The second action point is to develop and expand culturally competent maternity care for Aboriginal and Torres Strait Islander people. The third action point that I'm going to talk mostly about today is to develop and implement a national evidence-based birthing on country service delivery model. And the fourth one is to develop and support an Aboriginal and Torres Strait Islander maternity workforce. So a lot of those are actually all mixed up together in one, aren't they? And if we get the birthing on country model right, then I think we'll be able to we'll be addressing all of those. So what are we talking about? One of the things that the National Maternity Plan outlined is that they wanted a literature review done to look at the evidence both in Australia, New Zealand, Canada and the US around birthing on country service models. So models of care for Indigenous people that have actually made a difference, what's out there and has actually made a difference to outcomes. What the literature review found that there's not a lot of high quality evidence out there, unfortunately. There's a lot of the evaluations that have been done are small numbers and very short term evaluations. And despite that, there actually have been evaluations that have actually pointed out some of the key things that seem to make a difference to outcomes for Aboriginal Torres Strait Islander mums and bubs. And what that led to, after the literature review was done, the Commonwealth Maternity Services Interjurisdictional Committee held a workshop in Alice Springs, and that workshop was attended by over 60 people from across the country to talk about birthing on country and to try and define what birthing on country actually is. And there was a lot of talk and discussion about what are we talking about when we're talking about birthing on country. And I've got a quote here that I think is an important quote, and I'll read it out because I'm sure you probably can't all read it. But what it says is that birthing on country should be understood as a metaphor for the best start in life for Aboriginal and Torres Strait Islander babies and their families, because it provides an integrated, holistic and culturally appropriate model of care. Not only the biophysical outcomes, but it's much, much broader than just the labour and delivery, like we were hearing from Marianne this morning. It's deals with socio-cultural and spiritual risk that is not dealt with currently in our system. And that's the holistic model that we're talking about when we talk about birthing on country. The other parts of the definition that came out of this workshop was that it's important that the birthing on country projects moves from just being aspirational. So at the moment, you know, we've got loads of reports, haven't we? How do we do things better? How do we improve things? There's reports sitting on desks everywhere. I've read just about every one of them. There's over 50 from what I've seen in the past, and a lot of them are gathering dust, and they don't always actually end up in action. So it's important that this birthing on country agenda moves from being in the national plan to being an actual thing. The other thing that was there that I thought was important to point out is that Birthing on Country agenda relates to system-wide reform, and I think this is really crucial. It's perceived as an important opportunity to close the gap in Indigenous and non-Indigenous health and quality of life outcomes. So, and that's what it is, isn't it? It's system-wide reform. So it's the tertiary, the rural, the remote areas. It's everywhere that we need to make a difference. And we've got, from the evidence, from the ones that have made a difference, some of the strategies that we need to put in place are things like this. The continuity of carer, which we've been talking about this morning. Services that are community-based or community-controlled, or both. Services that provide outreach and home visiting, that are flexible, that have Indigenous staff employed in them. Services that are culturally appropriate. Working in partnership is really important. So on an individual basis, people like me, as a midwife, I've learnt most from the strong Aboriginal mentors I've had in my career. Mostly they've been out in very remote settings, but every remote place I've worked in, I've had the most extraordinary people teach me about how to operate in a culturally safe way, which I wasn't taught back in the hospital training days, but I went on and did further university training after that, and I wasn't taught a lot about cultural safety. It wasn't until I actually went out bush and worked side by side with Aboriginal health workers that I learnt about cultural safety, and a lot of that time it was actually learning by trial and error. I was making mistakes quite a lot, but I've learned a lot over 20 years, and I'm a bit better at it now. So it's working side by side, but it's not only on an individual level, it's the partnership. So it's organisations working together as well. Like what we're doing at the Mater, we know that as a large tertiary hospital, we can't make a big difference by ourselves. We have to work with the community-controlled organisations. So we've got a partnership with the Aboriginal Torres Strait Islander Community Health Service, and we've got a partnership with the Institute for Urban Indigenous Health. And together, the three of us will be able to make a difference. But alone, we can't do it in the way that we'd need to do it. So it's that community development approach which has actually been shown in the literature to make a difference as well. The evidence also supports that we can't do business as usual. We do need to change things, and we need to change them quite significantly. We've got a different workforce coming through at the moment. We've got students that are doing Bachelor of Midwifery degrees, so they're not nurses. So how do we work with them in our system? We have to change our models of care. We've got opportunities with eligible midwives. Midwives can now access Medicare. There's a different way that midwives can work, and that gives us all opportunities, particularly community-controlled organisations, for bringing in additional funding to help improve the services. I don't think we can reopen services the way we had them in the past. We have to think differently about how we're going to do it. And if we're setting up services in smaller areas, if we're looking at setting them up, we should set them up as level 2 services, so primary units that can chug along quite nicely as primary units, up to level 3 services where you've got those operating theatres and more equipment. But if something goes wrong and the doctor leaves town, then you need to be able to drop back down to a level 2 service. I think we have to be really careful with how we go about reopening these remote, rural and remote services. The evidence also supports changing the way midwives work, and the Minister has actually mentioned a little bit about this today. We've got fantastic evidence now, quite a bit of it generated from Australia, and we were involved at the Mater with one of the randomised controlled trials that's just been published in The Lancet, actually, which was fantastic, my claim to fame these days. But it's shown us is that when midwives work in a continuity model side by side with women, providing care antenatally, during birth, postnatally, so women get to know their midwife. They have a named midwife and they work in a small team, that this can actually make a difference. And the latest evidence has actually shown that it makes a difference to preterm birth. There's not a lot of things out there that have made a difference to preterm birth, but midwifery group practice can make a difference to it. So that's something that we need to actually look at with all of our models across Australia. And this is why I think it's this cascade of normal. This is how midwives work. We don't work in isolation to doctors. Of course we work with doctors, but we work across what's called normal birthing, and we get this cascade. This is Vicky Van Wagner from Canada developed this cascade, and I love it. We talk about in maternity, we talk about the cascade of intervention, where, you know, if you have an induction, you might end up with more pain, and then you might end up with needing an epidural, and then you might end up up with a caesarean section. She's turned it around to talk about the cascade of normal, and that's where you can birth close to home with your family members around you. Getting risk in perspective. We're so anti-risk these days. Everything's dangerous, isn't it? So it's getting risk in perspective. It's hopefully seeing pain as a normal part of childbirth, and then going on to have a normal birth with family close by, and hopefully for us, after talking today, birthing on country and understanding exactly what that means. So we've got some examples to follow. We've got some great examples that we're going to hear a bit more about, but we've got examples in the urban model. We've got new models that we're working with at the MARTA with the Institute and AICS that I mentioned. We've got the Narramar service, which is a new model here in Brisbane also. We're going to hear a bit more about, and the Townsville Mums and Bub services. So there are examples out there of how we can do things differently. Even in rural areas like Mareeba, there's examples. So I think if you're starting off, if you're from an area where you haven't, you want to get a new model up and running, don't start from scratch. Go and talk to the people that have already got up and got moving. And there's a model up in Darwin which I think is one of the best models for women in remote areas. So that's caring for women as they fly in from remote communities. And they've done the learnings. They've been doing it for 5 years now. That's another place that we can actually learn from. So just before I finish, I want to talk a little bit about primary maternity services, because this is an area that we're talking about if we're talking about getting services reopened in rural and remote areas. And the primary maternity services, they've got lots of names. Some people call them birth centres, some people call them primary units, some people call them, they're the level 2 units. And we've got some evidence that actually tell us. So these are the places where you can't get a caesarean section. So you'll have antenatal care will be provided there. You'll have birthing there for low-risk women. You'll have postnatal care and outreach services. And these services need to be integrated and attached to the higher level services if women need to go from the lower services to the higher services. So they need to be integrated. How safe are these sort of services? Look, I think we've got enough evidence to say they're safe. We've got a really large study from the UK that looked at women that didn't have risk factors, so low-risk women, birthing in 4 different places. Home birth, the primary unit, the birth centre that's next door to sort of embedded in the hospital, and the big tertiary setting. And for every indicator that they looked at, the primary unit was the best. It was absolutely the best for both the mums and the babies. So I think we've got the evidence from a very large UK study, but we've also got evidence from New Zealand. And New Zealand have got about 58 primary units, 51 in rural areas. Half of them are greater than an hour from tertiary services, and for those, they have terrible weather over there, so sometimes they get cut off from the tertiary services. But the service stays open. They don't close just because they're cut off, which I thought was really interesting. They're seen as really culturally secure services. The Maori tend to birth in these services and prefer the primary units, the smaller units, and around about 23% of Maori women will birth in a primary unit in New Zealand. And the way they've got it set up, it's safe. They've got good assessing of women and working with women to assess their risk factors. So they only have a 10% transfer rate, which I think is actually quite low. So about 90% of women that are planning to birth in these smaller units actually stay and birth in the smaller units. When we talk about birthing on country, particularly if we talk about birthing in remote areas, which I do sort of think we really need to think about and we need to do, if we talk about remote areas, people say, oh, crikey, it's too dangerous. Mothers and babies will die. I've been told that mothers and babies will die, and the care providers believe that they'll get blamed, which is a really significant issue and a really significant fear that needs to be addressed. We're told that nobody wants to birth in communities anymore. It's only the old women that want that, but just about every time you go out and do the research, women still say they do want to birth in remote communities, stay at home with their families. And there's also the fear around, well, if you set up a birthing service, a primary unit, then the women with risk factors will stay. But that's not what the evidence suggests. If you look at what we can learn from others, and I've just got a couple more slides, and this is learning from the Inuit, who have actually set up birthing services in really remote areas, 4 hours, 8 hours away from caesarean section facilities. And what they've found is that they've found that it's really important for the spiritual health and the healing of their communities. And this is an Inuit elder and a quote from him, and he said that, "I can understand that some of you may think that birth in remote areas is dangerous, and we have made it clear what it means for our women to birth in our communities, and you must know that a life without meaning is much more dangerous." And when you look at the evaluations of the birthing in the remote communities from the Inuit communities, it talks about building community capacity, about restoring skills and pride, building family and community, intergenerational support and intergenerational learning, the sort of things that we don't see in our remote communities because we fly the women out, don't we? We fly them out and we don't acknowledge their the knowledge and the skills that are already in those remote communities. And this is just the last quote that I think is also from a Inuit elder that's a beautiful quote, is that to bring birth back to communities is to bring back life. And I'm sure I'm not telling any of you anything to say something like that, but that's what they've found with, after now they've done more than 20 years birthing in remote communities. They've got statistics that are absolutely stunning that show us that it can be done, and it can be done safely, a long way away from tertiary facilities. But it does need to be set up properly and it needs to be set up safely, but it can be done. And it's exciting that we're here to be talking about it today. And this is what I'd like to see. It's gone. The sign where you have the dirt road, birthing services ahead. It'd be great to see that across the country, wouldn't it? Thank you very much.